right, okay. I'm going to have the doors closed. I'll go ahead and get started. This is a professional track, just to make sure you know where you are. Next door we have the breakout A, and down the hall is the breakout B. Just to let you know, FYI. Thank you, sir. And we have a Dr. Denise Meyer-Williams, who will be going to talk about why do patients do what they do. It's going to be a health literacy talk. And here's a little bit about Dr. Meyer-Williams. After retiring from the U.S. Army Nurse Corps, Dr. Meyer-Williams worked with the clinical studies involving the stress busting program for caregivers of persons with dementia and family caregivers of wounded warriors for 12 years. So that was a tidbit. Let's welcome Dr. Meyer-Williams.
Well, good afternoon. It's a real pleasure to be here today. And before I get started, I'm wondering a little bit about who my audience is exactly. So do we have any clinicians? Okay, nurses, okay, social workers, okay, family advocates or AAA people. Okay, all right. I'm obviously coming from a clinical perspective. As you can see by my title, I'm using patients. So it could be clients also. But today I want to look at why patients do what they do. And Joe, where's my purchase? Because and I asked this question because sometimes when you've been working with somebody, with a patient or a client, they'll come back and you sort of wonder where they've gotten, they're so off track of where you thought you were, that whether it's a treatment plan or a diet that you've discussed with them or a type of procedure, and you just sort of wonder, what happened? What did we talk about then? Why are we so off kilter or out of sync here? And I'm thinking particularly one sort of humorous, maybe it wasn't for her, incident one time was a woman who had been in a family planning clinic, and she came back pregnant and was wanting to know why. Because she said, every single day I faithfully took that birth control pill and put it in my vagina. Why am I pregnant? Okay? So we've got a little communication issue or something going on, that it wasn't exactly the way the plan was supposed to go. So today I'd like to talk to you about these times when we're a little bit out of sync with our patients or with our clients. And the objectives are going to be to identify some of these reasons and to look in particularly into the area of health literacy and how that impacts the person, the impacts of health literacy on people in our society, and identify some common communication problems that we experience, as well as to describe some ways that we can deal with our patients and our clients to make sure that we are on the same sheet of music. Being out of sync is sort of the way I've been looking at it, is not necessarily a local issue. I mean, it may happen with clinicians individually, and you may have this with patients, but actually this happens a lot in our society, in our healthcare system. And when you multiply how frequently this happens with different clinicians, and then the difficulty in navigating our, okay, I'm sort of behind on these. These were our objectives, okay, which I had said previously. But when you multiply, when you look at the disconnect that you may have with your own personal patients and clients, and this on a multiple provider situation, and combine that with the difficulty in the navigation of our whole healthcare system, it comes to be what one health affair article is described as a crisis of care. And it's a very costly cycle of a crisis of care, where people are not getting the full benefits out of healthcare that can be offered to them, that is being offered to them. So there have been some, this is so much recognized that there have been some national action plans taken, put in place by Congress in attempts to address this situation. And unfortunately, a lot of this material isn't necessarily very widespread. So what are these plans and what do they address? Although the tendency is a lot of times to blame the patient for not listening, or to, and unfortunately, that situation with that woman and the birth control pills was a real life situation, and some of the comments made by healthcare providers were not very complimentary towards that woman, like, how dumb can you be? Which may be sort of funny, but it's much sadder on a larger scale. But if we can get beyond the blaming the patient or the client for not following directions properly, it's come down to understanding that a lot of these problems are attributed to a lack of health literacy and the communication patterns that we have with our clients. Now, some of these national efforts these are some of the national efforts that are actually addressing the problems of the patient's inability to fully benefit from the healthcare system. You can see you've got a national project to address health literacy, to address how we write or give out our written information in pamphlets to patients. And there's a National Patient Safety Foundation. It actually covers a lot of different areas that you wouldn't think of really necessarily in terms of safety, but we'll cover a few of these. However, we find that health literacy is really a major culprit in this problem, in this area. Are you familiar with health literacy at all? Is this something that you've come across? Okay, I see a couple of heads nodding, but not a lot. And it really, for the most part, is not a real well-known topic, unless you hear what it is and then you'll say, oh, yeah. And it's basically the capacity of a person to understand basic health information and make appropriate health decisions. So it's understanding what you're being told by your healthcare provider, what you're finding in the literature, and then being able to apply it in your own life, and so that you can choose the best make the best healthcare decisions. And it involves not only basic literacy, so you have to have some basic reading skills, but also an ability to understand numeracy, or arithmetic and numbers, as well as an ability to access information. There may be a lot of information out there, but if you don't know how to access it, it's not going to do you any good. This is, I've got to remember to advance the slides. There's the only population level study of health literacy skills was done within the past decade, and it was done by the Department of Education, and they came up with 4 categories of health literacy that they defined as proficient, intermediate, basic, and below basic. And this is the percentage of population that is in each of these categories. And you'll see that the proficient category is only 12% of our U.S. population is in the proficient category. And that it involves adults who have the skills to manage their health and prevent disease, and then adequately navigate our healthcare system. The individuals considered to have below basic health literacy, which is about 12% too, in that same area, would not be able to recognize a medical appointment on a hospital appointment form, nor would they be able to determine from a clearly written pamphlet containing basic information how often a person might have a specified medical test. Persons with basic health literacy, okay, so that's up near the 30% mark, would have trouble providing 2 reasons why someone with certain symptoms might have a specified test, even when they used information from a very clearly written pamphlet. Patients in either of these categories may fail to understand critically important warnings on the label of over-the-counter medicine. So we're talking 42% of our population. The individuals with intermediate health literacy would be able to use an over-the-counter drug label in order to identify substances that might cause adverse drug effects. They'd be able to find the proper age range for certain vaccines requiring, given to children. But they would find it difficult to define a medical term from a complex document about an unfamiliar topic. So if they're picking up a pamphlet on dementia for the first time and looking at that, they may not be able to understand a lot of what's, all of what's being said. Those with a proficient literacy are able to calculate an employee's share of health insurance costs for a year using a table that shows how the employee's monthly cost varies depending on income and family size. So they're able to read a text like that and calculate. They can find the information required to define a medical term by searching through a complex document and evaluate information to determine which legal document is applicable to a certain healthcare situation. So you see, to readily be able to, and so these were the defining characteristics of the different categories. But when you look at this, add this to your thought and understanding of this, that 24 million Americans, that's 8.7% according to this one study, are not proficient in English. So, compounding the problem a little bit. So what happens when we have low health literacy? Well, these are some of the outcomes. We've got poor outcomes for chronic conditions, a greater likelihood of hospitalization. We have less knowledge of disease and the self-management and of health promotion behaviors of how to prevent disease. Among the elderly, there is a worse self-rated access to care, lower self-rated health, and higher rates of some chronic diseases, as well as a higher adjusted mortality, which is what people die more. Is what we mean by mortality rates, if we want to be clear about our terms. So, what do we do with this information? And how does that apply to older adults? We know that even healthy older adults can have experience some cognitive decline. And even in a well-educated, affluent population, over 30% of residents will still have poor comprehension of written healthcare material. 30%. Only 50% in this one study could accurately answer questions from a Medicaid application. I thought I'd give you some little tidbits about health literacy and where we are in our country with that. That most people need help with health information regardless of reading level. Even college graduates that you would expect would sort of know, don't expect. know. It's not something that we teach very well in our school system about healthcare and how to ask questions and how to understand the health information. There's an estimate that over 90 million people in the U.S. are at risk because of health literacy, simply because they can't take all that information and care that's there, but they can't access it because of the literacy level. That 1 in 5 Americans reads at a 5th grade level. Couple that with most healthcare material is printed at 10th grade reading level. Ouch. More than 66% of U.S. adults over age 60 have only adequate or marginal literacy skills overall. And to keep in mind that health literacy skills are not solely determined by age or income or educational level or racial or ethnic groups. Health literacy can go across any of those areas. So, is this you? What can I do about this? What's it have to do with me? Well, I'm glad you asked that question if this is you, because we've got some suggestions. One person's understanding of health literacy is not just the patient's poor literacy skills, but it also involves an insufficient attention of staff to a person who is engaging in the healthcare system, as well as poor communication skills. So let's look at how we talk to patients. The attention, if we were to look at the attention of the staff, we'll come to some of that. Some of that is a personal issue of how much we individual clinicians are able to interact and engage with our patients and our clients, and some of that is dictated by the organizational setup. But we'll be covering throughout this some ideas for both of those issues. But first we're going to look at how we talk to patients. And again, emphasizing that even highly literate people don't always understand our language. We're so immersed in our own healthcare world that we don't realize that we have a very unique and esoteric language that's not always understood by other people. And I have found myself that sometimes I incorporate some of that language into my everyday talking. So I was thinking, when I was pulling this talk together, of a time when I was giving directions to someone, and I said, well, you go down this road, and when the road bifurcates, and and they sort of looked at me like, what? And it's like, oh, I guess that's sort of a medical term, that not everybody would know that. And so you have to realize that, that's part of who we are, but you have to recognize that not everybody is in that world. So and even if they know the word, that we can put them in a different context, so they can mean something entirely different. For example, you ask a patient about how her stools are, and you get this look. Why is that? Because she's thinking this. Okay? Context. Or you might see an Alzheimer's patient walking in, and is having more difficulty walking than usual. So you turn to the caregiver and ask her caregiver how long her mother has been having difficulty with her gait. She looks at you like this, thinking, what does our broken gait have to do with my mother? So you can see, again, the words that we use are in a different context. And if we don't recognize the looks on their faces, they might not be following what we're saying, but they'll nod their heads, and go along with it. So remember what I said about the National Patient Safety Foundation might be doing things that don't necessarily seem to correlate with patient safety. Well, one of the things that they've done is to look at communication patterns with the healthcare providers and patients. And they find that 4 different kinds of words cause problems in communication. The medical words, we can understand, you know, they're frequently, just like we're talking about gait and stool, our special little language that we have. There are the concept words, which describe an idea or a notion. And then there are category type words, which describe a group or a subset that may be unfamiliar to some people. And there are some, and then value judgment words, which may be only clearly made clear to the patient by giving them an example or a visual to convey the meaning of it. So let's look at some of these words, because this is a pretty theoretical type thing. Let's sort of put it to use here. And look at some of the medical words. We might, you know, you can look at on the left side here and see some of these words that we might frequently use. A condition, you know, or you know, I've heard physicians talk about this lesion here. People don't always know what that is. And so you can see that if you can break it down and to be aware of types of words that are more difficult for people to understand, and some possible words that you consider using instead. Some of the concept words, like intake. What's your intake? My daughter's in the hospital right now, and it's amazing what they just assume that you know. And the nurses will come in, well, what's your intake been today? Okay. Without explanation. And, you know, if you don't clarify with them, they'll give you an answer. You know, they may not know what it is. But even, so we have to be careful about how we're interacting with that. Even something like options, to make sure that we understand, that people understand that these are choices. A third group is the category words. We might use, what kind of support do you have at home? And some people might, I mean, that's common when we're talking about with the elderly and what we need. But that again might not be readily understood when you're talking with people. So you need to say, you know, tell them what help do you get, whether it's money or friends, or so that you can really readily get the information that you need. This is in a real different format with the value judgment words, and I think I did this particularly because you need to be woken up after those 3 boring slides, and to see that this is a real important thing, a group of words that we often let go. We say, you know, this is just a temporary thing going on. Well, what does temporary mean? It can mean a lot of different things for people. These are examples of words that people know what they mean, but unless you put them in context and tell them where you are with it, that it's difficult for them. Moderately, you know, for instance, just explaining, well, moderate exercise is doing it enough until you get out of breath. Even excessive. What's excessive? I've had people, you know, nurses say, well, if you've got, if you have excessive bleeding, then you know, come back in. Well, what's excessive? And I remember having a patient come back one time with a cast, where there was a little wick of blood on the cast, and came back in all upset because nobody explained to her that, well, you're going to get little, you know, drops like that. That's not excessive, but to her it was. So she was back in the clinic for it, needlessly, because this wasn't clearly communicated to her. I thought we would sort of go over a little bit too about, I saw an interesting article on the culture of the elderly, And some of the things that that can be common among elderly, and one is the respect for what they call white coat authority, of the respect that a person comes in and it gives to the physician or the nurses or whoever's providing their care, which is not always present with younger folks today. But this is more true of elders. They said that the older culture is not always trusting of younger healthcare providers and caregivers, which is sort of interesting if you want to keep that in the back of your mind too, that sometimes you have to earn your trust, and so that people come to know you and know that they can rely upon you, because it's not going to be readily given unless it's earned. That elders are more compliant if they have a perceived value of what you're talking about. So you can tell them that it's sort of important to have a low-salt diet to keep your blood pressure down. But unless you put it in terms where it's really meaningful for them, that's for anybody, but particularly with elders, I guess, that the advice would be disregarded. I'm not sure about this one, but according to this one study, they thought that that healthcare can be considered undignified in certain respects. There's a tendency to listen more to peers than to believe what's in print, and that the role and expectations of family caregiving can vary a lot according to culture, and I think a lot of us have seen that. And it's very helpful to use success stories to captivate and to capture interest and curiosity. So storytelling is very helpful in working with folks. One of the things too is the role of religion and spiritualism varies a great deal, and it shouldn't be either assumed or disregarded. That can be addressed in your care. And older adults can have a preconceived notion about what's truly possible, as indicated by this woman here. You just can't assume that what am I trying to say? They may understand things. Okay. Anyway, I'll go to the next slide. I'm stumbling here with my words. Okay, some of the things that we can do to eliminate some of the potential cultural barriers are to be respectful when we talk with them, and not going on first name basis right away, but to use titles, and for all first-time visits, to be very welcoming and sincere, and to clearly identify our purpose and expectations of the environment. As for anyone, is to never make a promise that you can't keep. And not to be condescending. And I've seen this in a lot of care facilities of "come here, sweetie," or just a very condescending manner of working with folks. It's a delicate balance for someone with dementia, in being respectful and yet giving guidance. And we have to be aware that we still need to offer the respect without rushing people. And it's always a good idea to just to keep things simple and avoid real long explanation of things. And so communication suggestions would be to set a very respectful environment. And this is particularly for clinicians. I wouldn't be particularly comfortable with somebody who's looking at me like this. I don't know about you. But if you're wanting some feedback and some working together with someone, that you need to be aware of how you're coming across to that person. So with communication suggestions is the amount of information that's pertinent to the patient. Sometimes you can give them too much, and sometimes there's not enough. And really a lot about communicating is to have a give and take with the person so that you're using, and not only the amount of information that you give, but again, the type of language that you're using. And I meant to say that when, in the part when we were looking at the words, I was talking about this with my daughter, like I said, who's in the hospital right now, and she said, be sure and tell them not to talk down to people when they do know what you're talking about too. And so that's important too. And you can do that by picking up cues of how the person interacts with you, the type of language that they're using, and sort of adjust your language. So if you're saying something, it's, do you understand that? Are we following? Or, you know, are we on board? And seeking feedback. And that way, sometimes you don't have to, you know, go too low in your level, or, you know, too basic in your level of talking, but you can keep it up at the, where it's comfortable for both of you, without saving a lot of time. As she had just gone through with this one person who sat down and was telling her practically in ABC language what was going on. And she says, okay, bring it up a level, bring it up a notch. I'm not in first grade. So you have to be real careful with that. So some of the communication suggestions then are using multiple forms of communication. I think we're pretty good about that, of giving handouts, both talking with someone and giving handouts and making videos available, or telling them when they are. So it's the multiple forms, because different people learn in different manners. One of the real helpful things is this program called the Ask Me 3. Is anybody familiar with that? It's teaching, it's ensuring that when you're ever interacting with a client or a patient, that they understand three main things in the course of a healthcare visit. One is, what is my main problem? And it's amazing that sometimes people don't know that. Okay, when you start talking about a whole different issues going on. So what is the main problem? And what do I need to do about it? And why is this important? Remember we said before that people will engage more readily when they have a value attached to it. So if you can help them to understand why it's important. And so the program is reaching out to patients to have them ask these three questions. But as healthcare providers, if we know about this, so we need to make sure that they understand these three things, and that we can ask them about it, you know. And one is the show me, or the teach back method. And that is basically having them tell you what you just talked about. And I've done this in terms of saying, I just want to make sure that I've spoken to you very clearly today. So tell me what you understand about what your main problem is. And what are you going to do about that? Okay, and why is this problem important? So it's a more of a shared understanding where you come together, and so that you don't have a woman going home and putting a birth control pill in her journey. You know, that you can avoid some of that. You can avoid that because you'll know what they understand and what they need to do about it. There are a couple websites. Can you read those? No. That askme3.org is a good one, as well as there's health.gov /communication/literacy. But if you Google health literacy, the National Patient Safety Foundation is also another very helpful site. Do you have any questions or comments about all this? What do you think about this? Is this any? Yes, ma'am.
I've noticed through the years, I've been in the nursing home business for over 20 years, but I've noticed a trend is changing. For example, what you were talking about earlier was, I remember when I see a patient in the beginning. I normally see a patient in the hospital and then they go into the nursing home setting for rehab or whatever. And the patient would always tell me, okay, I'll go, but I don't want anyone touching me that has body piercing, like an earring on their nose or their lip or, you know, and all these tattoos. So that was like 5 or 8 or 10 years ago. So I think times are changing. I'm not getting those complaints anymore from the elderly population like I used to.
Oh, interesting.
It's interesting how that's evolved like that.
Yeah.
So it's just food for thought. I just thought it's
Right.
changed a lot.
Yeah, of how people perceive things and what needs are. And the important thing is that to have those conversations about what's important to them or you know, what their values
And you
are.
talked about trust. So I guess if someone takes care of you in the nursing home and they have tattoos or body piercing, it's how well you trust that caregiver.
Right,
So trust.
right. Which will give credibility then to what they say about why it's important to do something for safety or for their health care. Absolutely. Good thought. Anybody else? Yes, ma'am.
Well, again, you're thinking about assuming that even well-educated people who might find themselves in that category understand all this. I'm now 66, but last year I and my master's and PhD level friends from the University of Michigan could not understand that very well. I mean, it is so complex, and I am now educating people 2 or 3 years younger than me before they get there. So it is even that way with us,
Yeah.
understanding our own Medicare benefit. Just imagine. I mean, it was a real shocker to me. And my brother's even been through 3 workshops. He's retired from the post office, and he still doesn't understand.
And the irony of that coming from the government that is also promoting health literacy and make forms easier to read. I know. And yes, absolutely. The difficulty of the forms, the government forms that we have to fill out are, as well as navigating the system and how to access care.
And my ex-husband's a physician, and he's had patients,
Yeah, exactly. So even when we know that there are those complicated forms out for people who do have high literacy levels, think of a person then with a low literacy level looking at something that may be, you know, more simply written and how they may struggle with it too. You know, of some of the, you know, keeping track of their blood sugars or, you know, documenting information like that. We may assume that people understand that. You know, another example in inpatient settings are, and if anybody has ever been in the hospital and had dealings with pain, when people come in and say, okay, what's your pain on a level of 1 to 10? It's like, what? You know, if you don't know what they're talking about, you know, that these require some understanding of, you know, we are trying to measure your pain because we want to best help you with it. And the way we can best help you with it is to know where you are with your pain. And we can do that by measuring it. You know, and you have to go into it and take the time, take a few minutes to go into explaining what we do and why we do. And I have heard people say, I don't have time for that. You know, we've only got 15 minutes in a clinic visit or whatever, but you know, that's being sort of penny wise and pound foolish. Because if patients don't understand what they need to know when they leave, they're just going to be coming right back. So if we spend that extra time and attention, and some of that is just looking for nonverbal feedback of, you know, those looks on their faces, like, you know, what's going on here, and saying, is there something you don't understand about this? And how can I explain it better? And to put it on the onus on us. How can I explain it to help you understand it better? Because we do have a very esoteric language in healthcare. Yes, ma'am.
How do you deal with it? Like, I see a lot of clients, and the issue sometimes comes from
And that's some of the difficulty with our healthcare system, and that's what we're talking about, navigating the system and teaching patients to be proactive in their own care and to be keeping their own private records and knowing what medications. And that's where coming in, where you know your basic problem. You go through those three things. You know your basic problem and what you need to do for each physician, and to be able to have that and articulate with each physician that you go through. And that's why we have the movement of the development of medical homes right now. I don't know if you're familiar with that concept. It's a real exciting concept that is outside the government control, which is, the government doesn't have to dictate everything. But the healthcare system is recognizing that if you have a home where it's the central place and they keep track of all your different specialists and they keep track of all the information and they know what medications you're on, so you don't get into polypharmacy, and have the overlap. And if people can get into a medical home, go for it. It's wonderful. I know the VA system is implementing this within their system, but you see some, I know there's assigned shirts for a medical home insurance. People can go for care there. It's a physician's office or an office where they actively keep track of your entire all your health issues. So it's not just you don't just go to the internist for your blood pressure medicine and the orthopedist here, but at the medical home, they'll keep track of what the internist tells you. They'll keep track of, coordinate with the orthopedist so that they know what medications you're getting there for their cardiologist, and they coordinate all the care at the medical home. Yes. Yeah, and it's one is a little bit different for the specifics of how they work, and electronic medical records are very helpful with it. But that's a movement that's coming up that we can look for. Yes, sir. That is a really good question. I don't know if all of you heard of it. It's, how some people don't fully engage in their health care. And I think there are two situations. One is that they need to be given permission, okay? Because we're coming from, especially very older adults, maybe coming from an expectation where physicians were very paternalistic. I know the problems, I'll tell you what to do, and you do it, okay? Whereas younger physicians engage in much more shared decision making, where we're working together for your health care. And so some people prefer to just be taken care of and told what to do. And you can't do too much about that. But telling them that you have a right to be involved in your health care. And you can have these decisions with your physician. And I had to do that, we're going into, when I'm with the TRICARE system and going into the military hospital where they assign you a physician, and I go in and say, okay, this is the situation, this is what I expect of you, this is what I'll do to engage in my health care too. I won't bother you with little problems, but when I do, I expect you to to address them properly, and can we work together like this? Some of them don't like it. I go, fine, I'll find another one who likes it. So some of that is giving them permission and telling them that you can be engaged, you can do this, you can make these decisions, and the more you know about it, the better you'll be able to do. So, does that answer? Anybody else have any comments or thoughts about the situation?
another song. Into this house we born, into this world we're thrown, like a dog without a